So I'm Dr. Jeffrey Wolf from the University of California, San Francisco. I do primarily care of myeloma patients and co-direct the myeloma program there with my opponent in debate today, Dr. Tom Martin. I'm going to be taking the position that measuring minimal or measurable residual disease is ready for prime-time use in a clinical setting.
And hi, I'm Thomas Martin, also from the University of California, San Francisco. And my esteemed colleague here is taking the endeavor that MRD is ready for prime time, and I'm taking the opposite, and that MRD is just not ready for prime time. This will be a collegial debate because our offices border each other, but that said, we will debate.
So Tom, I don't think there's any question in the world of myeloma that measuring minimal residual disease as part of prospective randomized phase 3 trials will give us early surrogate markers that will help us determine which arm is going to do better. Do you have any problem with that?
No, I agree completely. And you and I talk about this all the time, that right now with current treatment paradigms, we're getting more than 90% of people into complete remission. We have to have a way to be able to better assign patients to further therapy after induction or after transplant based on a better test than CR in myeloma. So I completely agree that MRD is ready to be tested for.
So let me give you some examples of places where MRD could be, I think should be, and I think is ready for utilization in the clinical setting. Beginning, for example, with the maintenance setting. Many of our patients get treated with induction therapy followed by transplant and then are placed on maintenance therapy. And a good proportion of them, maybe even 70–80%, are in complete remission, meaning it's a strange term, complete remission. It just means we can't measure it anymore with conventional means, but we can measure it with MRD testing, that is the portion below the surface of the ocean that we can't see. And we put people on maintenance and we treat them for years. We have no clue what's going on with them. Many of them are in MRD 0 state for year after year after year, perhaps with toxicity from the therapy, certainly financial toxicity. And wouldn't it be helpful if we could identify a population that was MRD 0 year after year after year, who probably don't even need that maintenance therapy? Certainly our colleagues who treat chronic myelogenous leukemia have been doing this for years, measuring depth of response, and recently have studied the ability to stop drugs in people who are BCR-ABL negative for 4 times in 2 years. I think we're ready to start doing that in myeloma.
I couldn't agree more. That in myeloma, we're ready to get to that place. We're ready to get to the starting point. As you know, our colleagues in CML and other blood cancers do it from a blood test. That's one of my main problems with myelomas. At the current time, we're doing it with a bone marrow test. And there's some problems with the bone marrow test. That being that there is spotty disease in the bone marrow. You may hit a good spot and they may be MRD negative. You may hit a bad spot and they could be MRD positive. And that could be part of serial exams where it's just a matter of luck, which is a problem. I do think when we get blood tests, it will be much more ready for prime time. The other thing is the testing is, we do it by flow cytometry and we also do it by next generation sequencing. And you've actually showed us this at UCSF. You can send split samples to both and get a different answer to both areas. And that's a problem right now. And that's why I think, for us, and you've started this at UCSF, testing is a great thing. Making a decision based on it becomes a more difficult scenario.
I agree with you, Tom, that there are differences in the way we measure MRD, and certainly measuring by flow is not as sensitive as measuring by NGS. But assuming we could measure by NGS, you're saying to me that your only problem with this is that it requires a bone marrow. Well, the way I do a bone marrow, patients feel it's no different than a venipuncture. And so I'm saying to you that if in fact it was very easy to get this, would it not be easier to use the MRD testing? And I'll pitch one other point here, and that is that if I told you I had a patient who's been on, say, lenalidomide for 5 years, is having a bunch of skin malignancies, counts are low, lots of diarrhea, and the patient has been MRD negative for 5 years, wouldn't you be more comfortable just stopping than if I told you that the MRD had been up and down and up and down and now was starting to go up again? It hasn't relapsed by conventional measures, but you wouldn't simply just stop the Revlimid. Wouldn't you use the MRD a little bit to make that decision?
Yeah, I think in these individual cases, you can use some of these testing to work with the patient and do risk-adapted treatment, individual treatment. Are they having side effects? Are they having a really great response? Is it time to stop the therapy after a certain amount? But really, as you know, in myeloma, we're just at the paradigm where we're getting clinical trials that are testing MRD after induction therapy, then after transplant, then after maintenance, and then serially with risk-adapted strategies to say, okay, can we stop now? Should we escalate now? Should we just continue now? And those data, so as you know, we don't have those data yet. That's going to be when really I think MRD is going to be prime time, and we're going to be able to make decisions not just for that individual patient, but for many patients, which it's not that far off, but just not in 2019.
The question for this debate, though, is it ready to be used at all? Not in every patient, but even in one patient.
Well, I think most people are going to wait to do this study until they can do it for most of their patients, so that they know the answer. The other question that I have for you, and that it concerns me too, is there is a difference in the definition of MRD, or what to do in MRD, when the patient is as part of frontline therapy. And now we're getting data for patients that are quote unquote MRD undetectable after relapse therapy, right? Especially with daratumumab. And also patients that have relapse therapy and now are getting chimeric antigen receptor T cells, or the bispecific T cell engager antibodies, where we're getting data that these people are minimal residual disease negative or undetectable. But in fact, what they're really telling us is that they did a bone marrow biopsy and didn't see plasma cells, right? Some of these patients actually still have an M protein. They may still have detectable heavy chains or light chains. And so we're kind of starting to mix words when we talk about MRD. We need a sound definition. We need a sensitivity of 10 to the minus 6 in my mind. And we need to make sure that they're actually truly in CR. How do you think about that?
I think that certainly there are situations where MRD testing is not enough. It doesn't explain what's going on biologically. I think that as with all other approaches in medicine, it's not going to happen overnight. This is going to be a gradual appreciation of where we can use it, where we might not be able to use it, and people will take it up, some faster, some slower. But I want to bring up two other situations that are interesting, not as common situations where we've been using it, and I know that you're aware of this. One is the identification of what's a truly solitary plasmacytoma. Bruno Paiva, 5 years ago, and people don't talk about this much, identified using flow cytometry plasmacytomas that were either bone or extramedullary, and looked in the marrow at flow and was able to predict how well these patients were going to do, whether they were going to relapse with myeloma or not. And those who were MRD negative with a solitary bone plasmacytoma had a very, very low relapse rate, a very low rate of progression to myeloma, versus the others who were negative in the marrow and therefore were true solitary plasmacytomas. And this applied to the extramedullary as well, not quite as much. And I've been using this actually, and I think you have too, to identify who is a true solitary plasmacytoma. That's another place we could use it.
Well, I think that's a great idea. In fact, you have led the charge at UCSF on doing that, and I think we're all doing it now. And we should expand this actually to the MMRF, to the IMF, to other groups in places where we can make that definition, whether it's 10 to the minus 5, 10 to the minus 6, and follow those patients and see who relapses and when they relapse versus those who don't relapse. Yeah, I think that's a great indication for MRD testing.
And a final situation that you and I have used a lot at UCSF, and we hope others will pick this up, is situations where a patient presents with renal failure, is on dialysis, and will never come off dialysis and needs a kidney transplant. And you and I have been able to demonstrate in a number of patients that if they are persistently MRD negative, especially in the frontline therapy, they've got a very good chance of going many, many years, and our kidney transplanters have taken those patients to transplant. I think that's another good place for using MRD testing clinically.
Yes, I do think you have been on the front of the curve of MRD testing, no doubt about it. And you have certainly convinced all of us at UCSF that this is going to be the wave of the future. We need to test this. We need to follow serial exams, and we've been doing it. And you know that data from UCSF will be presented in Boston in 2009 at the working group meetings, showing that people who are persistently MRD negative are certainly the good prognostic patients. And so my final thing is that at the current time, MRD is a way for us to assign prognosis for patients that have received therapy. And you and I know that those people that are high risk, 17Ps, 14, 16s, et cetera, but achieve MRD negative and then persistent MRD negative, those people we don't have to worry about like we did before.
Right. So I agree with you that it's probably not ready to get out there and have everybody use this, but I think we really are on the cusp of using MRD testing for clinical decision making. Thank you, everybody. This was a friendly discussion like we have every day at work.
A very congenial discussion, and I hope people start testing for MRD. Just don't act on it.